Thank you very much for your kind introduction and also for the invitation. Can you hear me and see the slides?
Yes.
Yes. Okay. So again, thank you for having me. It's an honor for me for being in this meeting. I would like to be there in person, but this year wasn't feasible. So now I'm trying to speak a little about this tough situation about management of BLL after CAR T-cell relapse. So these are my disclosures. So as you can see, the prognosis of BLL patients after the first relapse is already quite poor. So it doesn't matter if you are a child or an adult patient, the probability of being alive at 5 years is not more than 10%. And this poor prognosis is especially poor after a relapse after an allogeneic stem cell transplant. So in this context, we have two new modern therapies, targeted therapies like blinatumomab and inotuzumab that have been able to achieve outstanding complete response rates in this population, but still these responses are not durable if we don't do anything else, mainly allogeneic stem cell transplant. But even on the right, even the patients that do perform an allo after achieving response, most of these patients still experience relapse. So we are talking about a clear population with a clear unmet need. So this is the context where multiple institutions have been developing several CAR T-cell constructs for BLL. And I must say that the sensitivity of the efficacy of any CAR T-cells, it doesn't matter if it's an academic, industrial, 4-1BB based or CD28 based, any CAR T-cells are able to achieve outstanding MRD negative complete responses. So the bar is really high, with a minimum of 70% of patients achieving the response. So this is great, but the problem is that this high response rate is also followed by that very high relapse rate. So with any CAR T-cell that has been published, at least 50% of patients will end up being refractory or relapsing after this. So every year we treat more patients. So this is an emerging population, so relapse after CAR T, an emerging population with a clear unmet need. So as you can imagine, the overall survival and the prognosis of these patients that relapse after CAR is quite poor. We're talking about a median of 12 months for pediatric patients and a median of around 7 months for adult patients as well. So trying to organize how patients relapse. So this will be sort of a summary. So we could say that relapse could be either CD19 positive or CD19 negative. So CD19 positive relapses occur mainly in the context of a suboptimal expansion or immune rejection of the CAR, T-cell exhaustion, that are usually preceded by B-cell recovery, and as well as loss of CAR T-cell detection. On the other hand, CD19 negative relapses usually occur in the context of an optimal expansion, a stable engraftment of the CAR T construct, persistent B-cell aplasia, active CAR T-cell detection, but with an antigen negative disease. So as you can see, the proportion of these two types of relapses might change a little bit from adult and pediatric patients. We might say that adult patients tend to have around 80% of CD19 positive relapses. And in the pediatric setting is a little bit more equal, more or less around 30 to 40% of CD19 negative relapses. So pediatric patients might have a little bit more CD19 negative relapses. And this matters. So both patients are equally relapsed, but patients with CD19 negative relapse might do worse. And this might be because both patients are relapsed, but CD19 negative patients also have another set of problems, which are basically the toxicities that are usually related to CAR T-cell persistence. That will be active B-cell aplasia and hypogammaglobulinemia, which are toxicities. And also, if you don't have CD19, then these patients also have one less target to treat, a very important target, which is CD19, which reduces the possibilities of management after relapse. So once we have a patient that relapsed after CAR T, we might need to think first to deploy unused therapeutic modalities. So, for example, if your patient haven't done an allo before CAR, that will be our #1 priority. And if on the other hand, you have a patient that has already done everything, which is quite usual in this context, then we might need to explore to repeat prior treatments that have proven successfully and might do the trick as well in the second term. So from all these treatment modalities, we have multi-agent chemotherapy agents. We have targeted immunotherapy with blina, we have TKIs, but all these therapies are able to induce new complete responses, but these responses will always rely on the possibility of the performance of, first of all, an allogeneic stem cell transplant after this, or a second CAR T-cell infusion. So for options for CD19 negative relapses, then we have some trials that are going on with CD22 CAR T-cells. So this trial was performed under the MSK, so with an autologous anti-CD22 drug that was used in a population of pediatric and young adults. So as you can see, this population was already exposed and failed to at least 2/3 of prior CAR-19 product, and have around half of patients with a CD19 negative population. So the interesting about the first trial is that it was one of the first of showing how this new safety signal, how CD22 CAR T cells were able to induce incidence of IHC hemophagocytic syndrome in around 32% of patients, which was a very severe toxicity, including also symptomatic coagulopathy and diffuse intravascular coagulopathy in 24% of patients. So for the patients that survived this toxicity, they were able to show a complete response rate of 70%, which is an outstanding response rate in this relapsed and refractory population. So as you can see, the only issue with this CD22 CAR was also that most responses were brief. So as you can see, only 2 patients remain alive and in remission on the long term. And as you can see, most of the long-term remissions are in patients that were able to be bridged to an allogeneic stem cell transplant after the CAR. And also with a relapse, median relapse-free survival of only 6 months. So then we have this second trial for CD22 CAR, which was basically performed with a humanized monoclonal with the idea of trying to increase persistence on the long run and therefore increase duration of response. Again, this was a trial for pediatric and adult patients. And again, most of these patients were in the context of post-CAR-19 relapse. So we have half of patients relapsing after CAR-19 and another half after blina. Again, this drug also showed this new safety signal with 19% of IHC-HS, which was, again, a very severe toxicity. But also, on the other hand, they were able to induce MRD negative responses in 56% of patients, which is also a great outcome. The problem is that, again, these responses were very short-lived with a median PFS of 77 days. And as you can see, the only patient that was able to achieve a long-term duration of response was a patient that was able to perform an allogeneic stem cell transplant. And a third and last trial with a CAR-22 trial that was performed with the UPenn group. So these patients were basically pediatric cohort of patients. They were all relapsed or refractory after CD19 targeted therapy, namely CAR T-cell therapy and blinatumomab. They were all CD19 negative. And what was interesting in this new trial is that thanks to the fractionated administration of the dose, not in a single shot, but an increasing step-by-step split dosing, they were able to have a 0% incidence of IHC-HS, and were able to retain a great response rate at day 28 with a 76% complete responses. in this population of refractory patients. So this was really great in this context of post-CAR-19 relapse. And as you can see, around a quarter of patients were able to maintain on the long run this duration of response. And again, most of these patients were able to do so by performing an allogeneic stem cell transplant after CAR-22. So if you don't have access to a CAR-22, which will be the case of most of the centers right now, then you could consider treatment with inotuzumab or retreatment with inotuzumab if you have a CD22 positive disease. There's very little data about retreatment with INO, and we have a very small population of 13 patients that received retreatment with inotuzumab, and where we found at least that 38% of patients were able to achieve again an MRD negative response, which allowed for the performance of a subsequent allogeneic stem cell transplant. There's another small communication about four cases of the use of inotuzumab post-CAR-19 relapse. So these were 4 patients that were able to respond, achieve a complete response, and they were able to be bridged to an allogeneic stem cell transplant. And 3 of these were able to maintain a long-term remission for more than 2 years. So again, if you don't have a CAR-22, then you could use inotuzumab to try to induce a new remission and perform an allo afterwards. So what about CD19 positive relapses? So in these cases, you can also use what we already told, but we can also try again targeting CD19. So this was this first experience with the Seattle group where they used leftovers for the first CAR-19 production. So they retreat the patient with 10 times the initial dose. And despite increasing so much the dose, they were able to induce a new MRD negative complete response in around 21% of patients with a median PFS of 28 days. So this study showed the importance of immune rejection once you expose the patient for a second time for the same CAR. So with this in mind, in our institution, we performed a study trying to reduce this immune rejection. So we tried to treat patients with a second time using the same CAR-TC, CAR-19 with the leftovers. We tried to increase the cell dose to 3 times, and we changed the lymphodepletion with the addition of rituximab with the idea to reduce humoral immune rejection. So after this, we obtained around 60% MRD negative complete responses with the second infusion. And from these patients, we found that a third of them were able to achieve a long-term duration of response that might sometimes be better than the first infusion. So we can still rescue some patients if you have leftovers of the initial CAR-T cell production. And with this in mind, we also conducted recently within the Go-CAR Coalition a multi-center study within the EBMT registry of second infusions. So we analyzed children and adult patients that relapsed after CAR-19 and received a second CAR infusion. And we found that within 345 patients that received CAR-19, 41 received a second CAR-T cell infusion. Of these, 34 patients received a second infusion due to relapse. So with active disease, as you can see, these all patients were, of course, very heavily pretreated. Around 80% have failed a prior allogeneic stem cell transplant, which limits what we will do afterwards. And also we have a high proportion of morphological relapse and extramedullary disease. So bearing this in mind, it was really surprising for us to see that second infusions was really safe. We didn't see any severe case of severe CRS or ICANS. And despite this, we were able to observe a 50% MRD negative complete response rate after this second infusion. So again, you can still rescue some patients. And also, we found a 2-year leukemia-free survival of around 40%, and a 2-year overall survival of around 54%. So the important thing about this is that, again, this was really dependent on the amount of disease that the patient had at the moment of second infusion. So the patient that arrived to the second infusion in CR, that means which were able to do a very good bridging and obtain a CR before the second infusion, were, of course, the patients that did better with a 2-year leukemia-free survival of around 66% and a 2-year overall survival of around 74%. So again, great outcomes if you're able to induce a CR before CAR-T2 infusion. And so the conclusions of this study was that second infusion was safe, and we were able to obtain a remission in 50% of patients. The only thing is that this second infusion was able to maintain long-term remissions as a standalone therapy only in approximately 10% of patients. So most patients that achieved a long-term remission with CAR-T2 were the patients that were able to be bridged to another allogeneic stem cell transplant. So what about non-CAR-T options, targeted options in this situation? Then we can also do retreatment with blinatumomab. So there's a trial specifically for this in patients that were relapsed or refractory after blina or CAR-19. And this is a very small trial that has been recently published, only 14 patients, where retreatment with subcutaneous blinatumomab was able to induce a new complete remission, MRD negative remission, in around 64% of patients, which again is outstanding in this population. The only issue is that there were only 4 patients with post-CAR-19 relapse, so we don't really know if these outcomes are general, could be applied to all the CAR-19 patients. So just to move to the last moment is allo indicated in the patients who do not respond or relapse after CAR-T? So this is the question. So there are some studies trying to analyze this. So this first study analyzed patients with adult patients relapsed after CAR-19 with the product from MSK. So we found 30 patients that were salvaged after CAR-19 relapse with the idea of bringing them to an allogeneic stem cell transplant. So from 30 patients that were intended for an allo, only 7 were able to be bridged to an allo. That's 23% of patients. But from these patients, only 1 remains alive and CR at the last follow-up. So that's 14% of patients that do perform the allo. So the problem is that it means that only 3% of all patients that were intended to go to an allo as an intention to treat were really able to achieve a long-term remission. This other study did basically the same, but in the pediatric patients, in patients relapsing after T-cell, after Kymriah. So from 50 patients that were salvaged after CAR-19 relapse, 38% were able to be bridged to an allo, so that's a better proportion of patients, of which a third of them died after the allo. So this improved probability of bridging to allo could be because of the type of salvage therapy that was administered, with more second infusion of CAR-T-cell therapy, and also a higher proportion of inotuzumab. So with these 2 strategies, they were able to induce a new CR in around 70 to 60% of patients. And also, we performed a study that was also presented at last EBMT within the GO-CAR coalition, where we analyzed the impact of the performance of an allogeneic stem cell transplant after CAR. So we analyzed any type of transplant, meaning patients that received as a consolidation, as a preemptive transplant. That means patients that were not planned for allo, but because of early B-cell recovery, then we tried to do an allo, and also patients that perform an allo after a relapse, a molecular relapse or a morphological relapse was observed in the patients. So as you can imagine, the patients that did perform the allo as a rescue, so after relapse after CAR-19, were the ones that had the worst outcomes. But even so, around 40% of patients were able to achieve a 2-year leukemia-free survival in this context. So just to conclude, we would say that CAR T-cell therapy has, in fact, changed the prognosis of relapsed BLL, but still less than half of patients will achieve long-term remission with CAR-19 therapies as standalone. So relapsed BLL after CAR-T is an emerging area with a clear unmet need. All the therapeutic options must consider unused therapeutic tools as well as previous response history. The retreatment with monoclonal antibodies, high-dose chemo, or CAR T-cell therapy, second infusion is feasible, but the long-term remissions with these studies will rely basically on the feasibility of a subsequent allogeneic stem cell transplant. And also, despite the patients that do perform an allo after CAR-T relapse have suboptimal outcomes, but the few long-term remissions in this context are only obtained with after allo. So long-term remissions after CAR-T relapse is a rare but feasible, and it's primarily depending on the uncommon opportunity of proceeding with additional cellular therapies. So that will be all. I will be happy to take any questions.